Welcome, everyone, to the latest episode of the Beauty and the Beast podcast. I'm Dr. Sam Jejurikar from Dallas, Texas. And as always, I'm joined by my co-host, Sal Pacella, plastic surgeon in La Jolla and San Diego, California, and a professor at the Scripps Clinic. Today, we're going to talk about a topic that could take us in a lot of different directions. We're going to talk about the current latest trends in plastic surgery, the ones that make sense to us and the ones that don't, as well as where we think trends are heading in plastic surgery as well. So I'm going to just open this up, Sal. In the last year or two, are there some trends that have started to develop in your practice that you had never seen before? And how are you dealing with them? And do you like them? What's the biggest one?
I would say by far the biggest trend we're seeing is, and I know we spent a whole podcast episode on this, is younger facial rejuvenation, facelifts in younger patients. And I think a lot of that comes from social media, the trends we see in celebrities like Kris Jenner having her facelift done, and minimally invasive facelifts, things like that. And, I think like we talked about in our previous podcasts, there's something to be said for trying to do a facelift or rejuvenation procedure in your middle age, 40, 50, because the benefit of tightening up the skin is in better position, the skin is in better consistency, you have better elasticity. It's a heck of a lot harder to take somebody who's 80 years old and make them look 50 than it is somebody 50 and make them look 20.
Yeah. And do you agree with this trend? Do you think it's a good idea that people in their 40s are coming in droves to get facelifts? Or do you think that's something we need to be watching out for as a society?
Well, I think in reason, you mentioned on a previous podcast that you have done a facelift on a patient as young as 18 years old,
Mhm.
right? And that was a patient who had a specific medical issue, a medical condition of weight loss, right? And so it really depends on the patient. Age is not necessarily a contraindication per se, but if patients have a lot of laxity to their neck, I routinely see patients who are in their 20s that may have a little bit of extra skin in and around the neck. Those patients have the benefit of maybe not needing a facelift.
Mhm.
They may benefit from a little liposuction to the jawline or a little microliposuction in and around the jowl. So the key is having all of these arrows in your quiver.
Yeah. I think there has been a big emphasis in society over the last 2 or 3 years on health and wellness. People are doing a better job of taking care of themselves. And I think this is starting to cross over into their personal appearance as well. You don't want to be overly aggressive in someone in their 40s. You can do less work on them than you can in someone in their 80s, but you can see a result that's really good. For me, I would say the trend that just didn't even exist 2 years ago and is now making a huge, 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 change in how I practice is GLP-1 medications. I see greater than 50% of my patients either currently on Ozempic or Mounjaro or Zepbound, or just having finished a course with it. And it has changed the paradigm in terms of how I treat patients. If I see a patient whose BMI is too high and wants a tummy tuck, before I used to tell them, you should lose weight to get a better result. But if you can't lose weight, maybe we can compromise and figure out a way to get this done for you. Now, we will actively help them lose weight before surgery to get a better result. Are you seeing a lot of GLP-1s in Southern California, or is this more of a thing in Texas?
100%. It's a huge process. And I think, what we're seeing is primary care doctors are more amenable to prescribing this. The GLP-1 medications have been shown in higher BMI patients and it seems like every week there's a new indication for it. We've seen them reduce the risk of heart disease, reduce the risk of potential for diabetes, reduce the risk of stroke.
Fatty liver.
Fatty liver, yeah. And I think as the research goes on and as the time goes on, I think the indications are going to be much wider. So I would agree with you. Over half of the patients I see are oftentimes on any of these medications. The interesting thing is, the insurance trends on whether or not you're seeing patients or insurance companies pay for these medications.
Now, I had a visiting plastic surgeon from Europe visiting our practice a few weeks ago. And basically, that plastic surgeon accused Americans of overusing these medications. They said that we were abusing them and we were applying them too freely to patients. I pushed back pretty heavily against that, but I'm curious what you think about that.
Well, I think there's, obesity is an epidemic in this country.
Mhm.
And, there has been, you see this in young children, right? young teenagers, preteens are heavier than they ever have been. Playing video games, not getting exercise. I mean, it's funny. I've had this discussion with a couple parents, which is, when I was a kid and I was being disciplined or bad, I got got sent to my room. Right now, when a kid is bad, he gets sent outside.
Exactly.
Right? Okay. So it's like, so I don't know if it's being overprescribed, but I think as a society, we need to understand what fat does and being overweight does to us long term.
Yeah, I mean, I would agree with that. There are health benefits to the medication, and even though you can sometimes achieve those health benefits through exercise and better diet, sometimes you can't. I will say though that there are challenges that are posed surgically that I'll see in patients on GLP-1s, particularly related to the elasticity of patients' tissue and the loss of muscle mass. Have you noticed similar things as well?
Absolutely. I think as the time goes on and as we study these medications more, you're going to see some indication that this not only reduces fat, but it reduces lean muscle mass too, which is not a good thing. Sometimes these patients are what we call sarcopenic, meaning they don't have a ton of muscle on their body. They're thin, they're wasting, they're cachectic. And I think there has to be a happy medium here.
Yeah.
But one question I do have for you is this. In your patients that have been weight loss patients that you've done procedures on some of these medications, and let's say it's a procedure where you've had fat transfer or you're going to do fat transfer, where does that fit in with them getting back on the medication?
Great. That's a great question, because I think there is using the medication as prescribed, which is to treat obesity and to treat diabetes, which are the major indications. And then there's what a lot of my patients seem to be doing, which is essentially microdosing it. So I think we would agree that when we're doing a fat transfer operation, we want to make sure the patient is at a stable weight, at least not going to lose weight. So if I'm going to do a fat transfer operation on someone, my goal is for them to be at a weight that they're comfortable at, knowing that if were to stop their GLP-1s forever, they might gain weight. But once they've gotten a few weeks out from the procedure, I'll let them go back and whatever low dose to maintain their weight. Because I'm never going to be successful, and you aren't either, telling a patient you can't take a GLP-1 again. That's just not going to happen. So what you have to do is figure out when they're going to be at their the lowest weight they're going to be at, or at least the lowest amount of fat they're going to be at, and then that's the time you can go ahead and
But let me rephrase that for a second. So what you're talking about is the quantitative amount of fat after fat transfer. Okay, so given the same weight of the patient, what I'm curious about is qualitatively, if given the same weight and they go back on their meds, do you see that the fat lasts longer or goes away quicker?
I don't know that I have enough experience following them out long term to know. My suspicion is that they will that the amount, the volume, the perception of volume from the fat's not going to be the same. I mean, I'm always worried about GLP-1s. And then my Brazilian butt lift patients who have started their GLP-1s at a high dose afterwards, they develop, what's commonly known in society as Ozempic butt, where they will lose a volume of fat from their butt afterwards. GLP-1s are here. We're not that far away from Eli Lilly releasing an oral form of it as well. So it's only going to become more prevalent. And so it's something that plastic surgeons need to learn how to deal with. Another trend that I am seeing a lot of, and I'm pretty sure you are as well, is a trend towards natural breast aesthetics and patients specifically coming in requesting their implant brand based off of social media trends. Are you seeing that? What do you think about that?
Absolutely. I think, in the 80s and 90s, it was all about big projected breasts, the Pamela Andersons, the Baywatch, et cetera. And I think as the time has gone on since the 90s and late 2000s, I think patients are seeing differences in breast implants. The longevity of implants may not be lasting the way they want it to. And they're looking for more of a breast preservation. A lot of patients come in and say, I want to look like my breast did when I was pregnant, or I want to look like my pre-pregnancy state. And so to me, that's a breast preservation procedure as opposed to more of a breast building or breast augmentation.
I think what you're talking about is how we do the operation. But what's interesting is for many patients, because of the direct to consumer marketing that we're seeing, whether it's Meghan Trainor going on social media and talking about Motiva implants, or whether it's Kylie Jenner going on and talking about Allergan Natrel implants. There are patients that are coming in that are specifically requesting what implant we put in. And although we will find that, we can get a great result with a Motiva implant when I'm pretty sure I can get a great result with an Allergan implant in that same patient as well. But patients in my practice are directing the implant at higher numbers than they ever have before, which, at times puts me in a difficult situation where I don't want to use the implant that they want.
Well, it's kind of a general shift, I think, in medicine. It's shared decision making for patients, right?
Yeah.
They have an idea of what they want. We should let them be involved with that decision.
Absolutely. Absolutely. So what's next? What do you think is the next biggest trend in plastic surgery?
So by far, I think the biggest trend is what we're seeing in society in general is AI in plastic surgery. I could tell you in my practice, AI has a significant role. I use it almost daily, from reviewing questions. If somebody is on a medication that I've never heard from, the first thing I do is go to ChatGPT. What is this medication? Okay.
Yeah.
The other, as you know, I do a lot of reconstructive surgery. I deal with a lot of insurance companies. One of the most efficient uses of AI in plastic surgery I've found is writing letters to insurance companies for denials.
Yeah.
It has saved me hours of time. And I think, the AI can integrate existing laws and quote them in your appeals for insurance companies. You can dial it up or dial it down based on the tone you want to take. And I've just found it totally brilliant.
The thing that's interesting about AI is we have not yet reached the point where AI has reached what we call super intelligence, where AI is going to be able to think independently and be smarter than people. Right now, you'll ask AI a prompt, it'll answer that prompt, but it's not necessarily thinking of like the next logical place to go with that. We're not that far away from it, as we've sort of seen. I mean, 2 years ago, I think anybody watching this probably never even heard of ChatGPT unless they were somehow involved with a company. Now it's ubiquitous. Like everyone uses it. Everyone is aware of it. Where we're going to be in 2 to 5 years is going to probably just keep growing at exponential rates. I too use AI a lot in my practice. I use an AI scribe. When I go in and I see a patient, every interaction is recorded and it turns into notes that are way better than the notes that I ever had before. When I do 3D imaging on a patient now, there's an AI component to it where we take 6 views with an iPad. The images that are created are ridiculously good. And what you can simulate on there and the level of realism is phenomenal. It'll do a facial analysis on the patient very quickly and point out, wrinkles and areas that need to be. It's amazing how accurate this is. And we're about 2 months away in my practice from now having an AI answering system for all online messaging for our patients, where basically patients will be able to schedule their appointments using AI directly into our system. They'll be getting they're not, we're still I'm nervous about letting it answer medical questions at this point, but pricing info, it'll have all the pricing info and it can generate quotes for people. It's amazing how far we're actually using it and how much it's going to just make the process more streamlined for patients.
And do you think that AI is augmenting the patient-doctor relationship or taking it away? Meaning, do you think it's bringing you closer to your patients as their doctor or not?
Absolutely not. But I do think it makes for a more efficient process, right? I mean, ultimately, you're asking me if replacing things that people do with computers, it makes life more personal. No, it doesn't. I think it makes the process more efficient, and like it or not, it's coming. The real question, though, is, in other surgical specialties, they are now using AI to do general surgical procedures, or they're training it, like taking out gallbladders or, doing colon anastomoses. What do you think is going to happen with AI and the performance of plastic surgery?
That's a great question and a scary question, I think. I think we're decades, if not eons, away from AI doing surgery. And, if you think about, can AI at this point in my life and on our lives replace the doctor-patient relationship? No. But I think we're going to use it and we're going to hold control over this as humans. But I think it will help us in our decision-making with patients. For example, in the radiology world, okay, it has almost taken over for diagnosing breast cancers and deformities on an MRI and CT. Is that going to happen with plastic surgery? We may be at a point someday where we'll be able to upload facial photographs to a patient and AI will analyze them and tell us, here's what you do. Boom, 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 boom.
Yeah. The future is uncertain, exciting, and scary all at the same time. Well, unless you have any other closing points, this has been an exciting topic as always. And thank you, as always, for watching the Beauty and the Beast podcast. Until we meet again.